And we developed something called a performance indicator of colonic intubation. And basically, this was the number of procedures done in the audit where we were using very light sedation, where there was cecal intubation and an acceptable patient comfort level. And overall, 54% of colonoscopies achieved that level. For my own practice, it's, to give you an idea, it's 85% at least. Some of my colleagues are up to 90%. So in England, we have a practice of using relatively low sedation. Some might say too low. And I would put it to you, would you want, what sort of person would you want to do your colonoscopy? Would it be someone who can get to the cecum with very little discomfort, using very little sedation? You need to be very good to be able to do that. Very impressive stuff. And in the middle here, so in this sort of 2006, 7, 8, remember, these self-reported scores were being validated by external assessors. So we do believe these scores. So what happened to quality? Well, I told you earlier that this process was applied to England, but not in Scotland. And Scotland has a screening program, or at least had one, that was virtually identical to England. And the Scots reported in 2018 their adenoma detection rates in comparison with England. Basically, I mean, this is largely a schematic, but the bottom line is that the rates in Scotland stayed static, but they improved steadily in England. And a couple of years after this reporting period, are up to 49%. Now, this is for GIEQ-based FOBT screening, not FIT. Okay, so FIT, we might expect another 10 or even 20% more than this. But this is for GIEQ-based screening. This is a big difference. Now, there were lots of other differences between Scotland and England, but one of the big differences was England required services to be accredited and Scotland. Well, it's very clear from our experience that if you don't have coordinated leadership at national level, everything underneath it becomes untenable. So I think it's really important that surgeons, physicians, nurses, and patients work in partnership to develop a strategy for high quality and safe endoscopy. Agreeing what standards framework you're going to use, having ways of measuring it, having training programs to pick up poor performers, a national KPI reporting system if you can, and a governance oversight group like the JAG. It's important that you get leadership at regional level. More specifically, I would say that we need systems in place to monitor KPIs and feed them back to people. We need a way of managing poor performance, and I could spend a day talking about that. We need support for those in need of further training, and we need to make sure that we're using our resources efficiently. What about individual endoscopists? Well, like I said before, you need to make the assumption you can be better. I think I'm quite a good colonoscopist. I teach a lot. Do I think I can get better? Of course I think I can get better, and I do think I do get better with time. And it's rare for me to go a week or a month without thinking about what I'm going to do differently to improve. We should be measuring and benchmarking our performance, and we need to be proactive about identifying training needs and doing something about them. And if we're not meeting the minimum standards and we've tried to get better, then I think we should stop doing whatever we're doing. I think there are too many people doing small numbers of highly complex procedures, and that's really not good for patients. So I'll leave you with the ESGE framework. I strongly encourage you look and read this. I feel incredibly passionate about this. I think this is really important to get this right. What we're talking about here is creating a safe, patient-centered environment, and critically an environment that we as endoscopists can work in and do what we enjoy doing so much, and do it safely and really well. Thank you very much.
So to conclude, I think for any diagnostic procedure, we should discuss first with the patient, can we do an unsedated procedure? This has many advantages for the patient. He can go home, he doesn't have to stay, he can work the same day. If sedation is desired or required by the patient, there is a lot of evidence supporting the safety and cost effectiveness of non-anesthesiologist administered propofol sedation and the improved experience of the colonoscopy by the patient it delivers compared to midazolam-based regimens. Endoscopists in countries as Belgium, where non-anesthesiologist propofol sedation is prohibited momently, must engage with our anesthetic colleagues over this issue and of which patients are suitable for this to temper the majority of our anesthesiologists' concerns and ensure safety moving forward.